بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله النبي الأمي الأمين. Welcome everybody. Welcome Dr. Isa for our new session today. Its topic is glomerular disease post-kidney transplantation. Actually, the presenter will be Dr. Shimaa Sheidi from Sohar Hospital. She is consultant nephrologist. Welcome, Dr. Shimaa. Actually, we are waiting for this interesting immunological lecture. Okay, you can start now, please.
السلام عليكم. بس شوي بس. So, good evening, everybody. I'm glad to present to you about. I will start my talk with two cases that I encountered recently in Sohar Hospital. So, and after that, we'll discuss briefly about we cannot discuss about glomerular disease before discussing something about proteinuria, then some glomerular pathology post-transplant and recurrence of GN after kidney transplantation. We'll start with the case. She is a 37-year-old lady, and she is post-living unrelated kidney transplant in February 2016. Her native kidney disease was crescentic GN. On May 2015, she presented with a severe renal impairment requiring dialysis and pulmonary hemorrhage. And her serology at that time was positive for BNCA and MPO more than 200, and the kidney biopsy confirmed crescentic GN. Although her kidney biopsy was not of a good favorable outcome, I decided to treat her with the steroid pulmonary plasma exchange and rituximab. As expected, she did not recover and she became dialysis dependent, and she was on dialysis for about 10 months before transplantation. Post-transplant, her course was uncomplicated, and she was kept on cyclosporine, MMF, and prednisolone. And she was on follow-up every 3 months as usual in any patients in transplant clinic with extended graft functions with no proteinuria. On May 2023, in the follow-up, suddenly in her follow-up visit, and she was asymptomatic, she came in with a serum creatinine of about 143 with eGFR of 143. Sorry. No, I'm sorry about the eGFR. I think I missed. I think her eGFR was about about 43. Her urine albumin creatinine ratio was 391, and with the urine analysis, she was microscopic hematuria, and her serum albumin was about 33. And 24-hour urine protein, total protein was 4.8. At that time, patient was admitted and she was evaluated, and graft ultrasound was done, and all causes that can explain her AKI was investigated, and at that time also serology ANCA was sent. And patients and counsel about kidney biopsy. Her kidney biopsy, as you can see here in this side, that it shows the necrotic vessel. And here you can see one glom with crescent, and her C4D was negative. So she was diagnosed as crescentic GN, ANCA vasculitis as a recurrence in her transplanted kidney about 6 years from her transplant. And she was managed accordingly. Actually, she is currently, I think she is in management in Royal Hospital, and she received rituximab. Case 2, this is a 34-year-old man, and he is post-living unrelated kidney transplant in 2006. His native kidney disease was posterior urethral valve, and he was about at age of 17, probably. He was on hemodialysis for about 3 years before transplant. And he was transplanted, post-transplant. He was complicated with the disseminated varicella zoster, and he had an AKI requiring dialysis, and then he recovered. And since his recovery, his serum creatinine was about 117 micromole per liter, which is about 68. noticed during follow, and he was kept on intensive aspirin, azathioprine, and prednisolone. And as usual, follow every 3 months. And with that time, a patient found that he was having progressive proteinuria. That was confirmed with the screen with the urine albumin creatinine ratio and confirmed with 24-hour urine protein 1.8, 1.9, and 3.8 gram. And with also associated with progressive impairment in graft function. And every visit was also discussed with the patient, the indication of graft biopsy, and he was reluctant. His serum creatinine during follow-up continued to deteriorate with 243 with the eGFR of 28. And then finally, he decided, like since May 2017, he decided to go through a kidney biopsy, and he had it in November 22. So I don't have the images for the biopsy, but I have the report. So the microscopy shows 11 glomeruli were present, 4 were obsolete, and 2 show multi-segmental scar. And the patent glomeruli shows mild focal segmental expansions of the mesangial matrix and cellularity when moderate IFTA. IF was negative, and the diagnosis was FSGS. So as you can see from from both cases, the common thing was the glomerular disease. And you can see the different nature of the disease between the case 1 and case 2. So case 1, you can see that patients have rapid sudden deteriorations with the sudden proteinuria, and a patient who is already known diagnosis of glomerular disease prior to the transplant, and she has again the same disease with a transplanted kidney. The other patient, he is like with a posterior urethral valve as a native kidney disease, which is different than the GM, but he had we can still classify it as a glomerular disease with FSGS, a post-transplant that happens like about 17 years post-transplant. So that's why triggered my reading and my thinking to present this topic. And we'll start with the proteinuria after kidney transplant. So proteinuria after kidney transplant is quite prevalent. And the prevalence varies between 7.5 to 45%. And this depends on the degree of proteinuria that you use on these studies. So if any proteinuria up to 45%, they have a proteinuria. If it is more than 1 gram per day, and the studies report around 19%. If it is like more than 2 to 3 nephrotic range, the prevalence is become less, about 13%. So it's quite common to have a proteinuria after kidney transplantation, but it's less common that to have like a nephrotic range proteinuria. So why is important proteinuria after kidney transplant? It is important because it has been associated with the kidney damage, and it's also predict the graft loss. Not only that, it's also associated with increased risk of mortality and cardiovascular disease events. And when you think about the source of proteinuria after kidney transplantation, especially in a patient who are having preemptive transplant, or a patient who on dialysis would have a significant residual urine output, you think about proteinuria is coming from the native kidney or coming from the allograft. So how we can differentiate? Here in one small study in Australia, they have like a 14 patient, look into 14 patients. Half of them have, all they have lived donor transplant, and half of them were transplanted preemptive, and half of them were on dialysis prior to the transplant, but all have residual urine output. And you can see that by week 4, we're measuring the urine protein creatinine ratio weekly, and by week 4, almost all the patients normalized the proteinuria. Here's another study with a bigger sample, and with also it was living or diseased donor transplantation, and they confirmed the proteinuria using 24-hour urine protein, and they did it at 3 weeks and after 1 year, and you can see almost most of the patients, they dropped the degree of proteinuria by 3 weeks post-transplantation. And also they found that there is associations between the degree of proteinuria at 3 weeks with the proteinuria pre-transplant. The higher the proteinuria, the pre-transplantation, they will have a higher proteinuria at 3 weeks of transplantation. So from this we can conclude that in the early post-transplant period, up to 1 month, the proteinuria is from the native kidney, and after transplantation with the reductions in filtration rate from the native kidney, after successful transplantation, the proteinuria should resolve. So any proteinuria happen after that, it is indicative of allograft pathology. And the proteinuria that's happening later after 1 month of transplantation, they found it also, it has been associated with that. The degree of the proteinuria is associated with allograft pathology. You can see here the glomerular disease have the highest urine protein excretion. I mean, when they did the kidney biopsy in these patients, the highest proteinuria was in the glomerular disease. Also, not only that, the degree of proteinuria is associated with the prognosis for the kidney of the allograft. So you can see the higher the albuminuria, there is high increase in the serum creatinine after 1 year with the eGFR, which was statistically significant. And also the urine protein, you can see that with increased urine protein, there is increased risk of hazard ratio of graft loss. This is as a reference of less than 150 milligram per day. And you can see that increased risk if it is more than 3 grams by 19 times. If it is a small degree of proteinuria, between 150 to half a gram per day, it is associated with increased 4 times increased risk of graft loss, regardless of the cause. Also, the risk also with the proteinuria in allograft that has been associated with increased risk of death from cardiovascular disease. So diagnosis, how we are doing in diagnosis of proteinuria in post-kidney transplant. Here in one small study, in one big study, they have looked into the patients with after transplant, and they found about 40% of renal allograft recipients develop proteinuria after their course of transplant. 15 of these patients actually have a nephrotic range proteinuria. Only half of them, they are going a diagnostic kidney biopsy. So not all, although it is very common, not all patients, and also associated with a graft pathology, not all patients, insignificant amount of patients getting a kidney biopsy. And if you can see by time after transplantation, if you do the kidney biopsy, you can see the glomerular disease usually start like steady increase in the incidence of glomerular disease with time, in comparison, for example, with acute rejection. And when they look into the patients who have a graft failure and found out if these patients who's having kidney biopsy with a graft failure, they found that significant number of these patients actually have a glomerular disease. It was about 11. This is all of retrospective like observation. However, when they did actually one study, it's about 1,000 patients, and they did surveillance biopsy. And they found the incidence of glomerular is even higher than that, is about 37%. And the incidence of graft loss, as it was with the glomerular disease, is usually later in transplant compared with acute rejection. And if you divide the glomerular disease, you can see that the recurrence usually happen earlier in transplant compared with the transplant glomerulopathy. If you classify transplant glomerulopathy as a glomerular disease post-kidney transplant. And de novo is less, and it is later in transplant. So, as we classify post-transplant GN, can be classified either recurrent GN, which is patients already known and have a diagnosis of GN prior to transplant and have the same diagnosis after transplantation, or could be a de novo GN. When GN is different, patients have a GN after transplant, which is different from the native GN that they had prior to the transplantation, or allograft GN occur in patients without native kidney disease, or not. I mean, you know that the patient had not having a GN prior to transplantation. And also there is another classification with the post-transplant GN with unknown primary disease. In patients, you would think they have a GN prior to transplantation, but it was never proven by a kidney biopsy. So GN and transplant is a very important subject in transplant because there are increased number of patients on end stage on dialysis going into kidney transplant with a pathology of a GN. For example, in Australia and New Zealand population, up to 50% of the patients who's getting transplant actually have a GN as a primary disease. China, about 48%, US, about 30%. And actually, maybe the prevalence much higher because not all patients undergo kidney biopsy before transplantation. And so many patients remain undiagnosed. So they are a specific population that need a specific important aspect in transplantation with counseling prior to transplantation about the risk of graft failure in these patients, what are the risks of graft failure and risk of recurrence. And most importantly, these patients are younger, so they survive longer. So we need to do our best to preserve the graft function as long as we can, and especially if the patient have recurrent GN. When you look into the GN and transplant patients, you can classify the GN as high volume, which is most common GN, with low volume, less common GN. And then you can further classify with a high risk of recurrence or low risk of recurrence. And then also, if you have a recurrence, it can be classified as high risk of graft loss or low risk of graft loss. For example, you can say that FSGS is very common and with a very high risk of recurrence post-transplantation and very high risk of graft loss after transplantation. In comparison with, for example, anti-GBM. Anti-GBM is less frequent GN disease, and it have low risk of recurrence and low risk of graft loss if you have a recurrence. So the recurrent is mostly the main focus of discussion with these patients because it's unpredictable. And if you want to see how frequent was that, here one study in Australia and New Zealand as well, they wanted to look into the protocol biopsy that has been done during the period, a study period. And in these, they found when they look into the study population that they found that about 10% of the patients had recurrence of a GN. And out of these patients who have a recurrent of GN, about 200 lost their graft due to recurrence. And when they look into the risk factors for recurrence GN, they found that age is higher risk of recurrence in these patients. And as with a younger age, they have a higher risk of recurrence. Using prednisolone after transplantation was protected from recurrence, but that was shown actually in IgA nephropathy. And the total ischemia time was, the shorter the ischemia time was unpredictably higher risk of recurrence. But also it was unpredicted finding that could not be explained and found only with the IgA nephropathy patient, and its significance was unknown. And hazard ratio for disease recurrence, according to the age, as you can see, the younger the patient, they have a high hazard ratio of recurrence of the disease. And this also, the risk of recurrence is varied by GN type. You can see that the FSGS, they have like maybe 2 weeks early in transplant and later in transplant. The MPGN, the MPGN high risk of recurrence. And IgA nephropathy, it is like, could be, you can see the recurrence is like a steady increase with time. So when you think about the risk of recurrence, one of the questions come is, what is the role of transplant immunosuppressions in risk of recurrence? Is there any specific regimen can protect from recurrence? All studies have reported no significant association between type of transplant and immunosuppression and the risk of GN recurrence. However, it might be a modulating effect of the immunosuppressions on the disease. For example, SLE is one of the disease that can recurrence, lupus nephritis. But after transplant, unexpected low incidence of the recurrence of SLE in these patients. However, when in the studies that included the protocol biopsies, they found actually there is a histological evidence of recurrence SLE in these patients, about 25%, but are not clinically, it remains subclinical. And also steroid-free immunosuppression found that increased risk of recurrence in pediatric patients and IgA nephropathy, but it's not affecting the risk of recurrence in FSGS. And also in transplant with membranous nephropathy, with the positive anti-PLA2R, they found that the level of anti-PLA2R decreased significantly after transplantation. So from this information, we can conclude that immunosuppression, it might not affect the recurrence. However, the immunosuppression had a modulatory effect on the transplantation. So when you look into the impact of GN graft survival in this patient, you can look into it in different ways of effect of GN on transplant. Look into risk of allograft failure, whatever the cause, compared in general population who have not have a GN, okay? And also look into the risk of graft failure in a recipient whom recurrent develops. So if patients have a GN and recurrent GN, what's the risk of graft loss? And risk of also to look into a different way to look into it, actually also to think about risk of graft failure in a patient who have end stage attributed to presumed advanced GN or a patient who have unknown cause. So let's go to look into the impact of these categories one by one. So in the patients with a biopsy proving GN, and when they look into the survival of the allograft, you can see that recurrence comes as third as cause of allograft loss after the death with functioning grafts and chronic rejection. However, this one is shifted with time. You can see it's different at the beginning of transplantations. Acute rejection came first, and then death with functioning graft. And probably the recurrence is coming later with the chronic rejections, unlikely at the beginning of the transplant. And I predict that also these can be changed with time, because there's so many advantages. There is so many changes in the treatment of GN. As you know, there is more understanding of the glomerular diseases and more understanding about therapeutic option of these patients. So maybe better control of the GN, and maybe so you will. So these even the prevalence can change with time in the next decades. So if a patient have a GN, the question, and then he had a recurrence, what the risk of graft loss in this patient? You can see in here in this probability of death-sensitive allograft loss in a patient with no recurrence, and compared with the patients with, sorry, this is with a recurrence and this is with no recurrence. So it is like the patients, if have a recurrence, if have a GN with a recurrence, the high risk of graft loss, either death-sensitive or overall graft loss. And look into the recurrence. So you can see that here in this study, they tried to find out the hazard ratio of recurrent GN on allograft loss. And you can see with a recurrence, the hazard ratio increased by 3 for death-sensitive graft loss, and overall graft loss also increased by 2. So you might counsel your patient going forward into a transplantation, the risk of recurrence and graft loss, it will be higher if they have a recurrence disease after transplantation. And also this one, although the recurrence become the leading cause of allograft loss along the different types of common GN, and also they can have other reasons for graft loss as well. But still the recurrence is the highest reasons for graft loss in these patients. And you can see if they have a recurrence, their hazard ratio also varies by the type of the GN, and worse with the MBGN. And this is when they compare a patient with a GN with recurrence, or compare with the patient without recurrence. And you can see that also here's another representative the same time, but you can see here appreciate the time interval of graft loss according to the type of the GN, as MBGN usually early in transplant. Overall, it is the worst, but early in transplant, along with FSGS as well. And if a patient's, and in that study, they found the median time to graft loss for those who lost their allograft due to recurrence and graft chronic allograft compared with the chronic allograft nephropathy, if they have the grafts survive up to 5 years, but if they have chronic allograft, compared with the chronic allograft nephropathy was 9 years. So significant reduction in graft survival with recurrence. In the same study, they tried to look into what are the risks of allograft loss. If a patient have a recurrence, what make him more likely, what are the risk factors make him more likely to lose the graft if they have a recurrence? And they found it depends, as we said, according to the type of the GN, as well. Being a male, it is high risk of graft loss if you have a recurrence, and increase in the PRA as well. By 10% increment, this was associated with increased risk of recurrent of graft loss with a recurrence. And in the United States, with a big study population, they look into all the patients transplanted from 1996 to 2012, and they try to compare how the patients with the look into the all causes of allograft failure by the cause of end-stage disease in a GN. They compare it with a diabetes and adult polycystic kidney disease, and you can see, although with diabetes there is increased risk of death with functioning graft, it's with the GN is less. That most of the GN they have more of graft loss rather than death with functioning graft. However, overall, also you can see that IgA nephropathy is better than others, and it's better than others, but it's still worse than adult polycystic kidney disease. But however, when they look into the overall impact, the graft survivor, regardless whatever the cause of graft loss, recurrent GN or no recurrent GN, when they compare it with the population, who have no GN at the baseline, there was no significant overall cause, all causes significant difference in graft survival. So we can say that these patients, when you counsel them, the risk of surviving allograft, it is the same as other type of renal disease. What about patients with have end-stage attributed to presumed or advanced glomerulonephritis or unknown cause? The incidence is reported to be like patients, he is end-stage with a proteinuria and you think he might have a presumed GN, but could not be diagnosed. And this patient, the incidence is about 10%. And or you have a patient in the stage, unknown etiology, and you don't think it is because of a GN. And so the incidence about 25% reported to be. And in these patients, if you compare the incidence of GN-related graft loss compared with the patient who already have a GN, diagnosed a GN, you can see that the incidence of graft loss in this patient is lower. So if you encounter this patient when they counsel them for kidney to go for kidney transplant, you can probably say that they have risk of GN-related graft loss in the future, even if you think that his GN the end stage is caused because of GN. Probably their incidence of GN-related graft loss is much lower than the risk of patient who already diagnosed with a GN. So in summary, recurrent GN is a concern for the clinician and the patient. Disease recurrence remains an important cause of allograft failure. And it is communication, counseling with the patient, education about before going for transplantation is very important. Selection of recipient and donor should be different. Should be no different from the patient with no GN, as overall graft survival, it is the same. Although there may be very important aspect when you're dealing with these patients, risk of recurrence and risk of graft loss. So maybe more surveillance, these patients to be treated differently from the other populations transplanted without a GN. And that's all my presentation. I'm open for any questions.